Welcome to the Deep Dive. If you need the shortcut to fluency in advanced pharmacotherapeutics, well, you're definitely in the right place. Today we're doing an in-depth exploration, really getting into psoriasis pharmacotherapeutics, pulling out the most essential clinical stuff from chapter 14 of your source material. Psoriasis is so much more than just a skin thing. It's chronic, it can be debilitating, comes with these recurrent flares, affects maybe 2 to 3% of people in the U.S. And while we often focus on the visible plaques and scaling, we really have to remember the human cost. There's physical pain, cracking skin, and even psoriatic arthritis in about 10% of patients. Our source material actually highlights this pretty staggering statistic. Up to 25% of patients felt they'd rather be dead than alive with the condition. That just underscores how vital effective treatment is.
It really does. And to treat it well, you need to understand what's actually going on, the fire underneath, so to speak. Psoriasis is fundamentally a T-cell mediated inflammatory issue. You've got this dysregulation where T cells are driving abnormal signaling, which leads to that rapid hyper-proliferation and abnormal differentiation of the skin cells, the keratinocytes. And it's not just local. The systemic release of these inflammatory cytokines connect to other chronic health issues like cardiovascular risk and, of course, joint problems.
And certain things just seem to make it worse, like pouring gasoline on the fire, as you said. We know stress is a huge one, maybe linked to 40% of flares. Physical trauma can cause that Koebner phenomenon. And the source specifically lists medications, too, like stopping systemic corticosteroids suddenly. Also common drugs like lithium, antimalarials, and beta blockers. The source mentions propranolol, which is a really crucial detail for advanced prescribers to keep in mind.
Absolutely. So our mission today is really to get past the textbook definitions and synthesize the actual therapeutic strategy. We follow a pretty strict hierarchy. Topicals first, then what we call conventional systemics, and finally, the biologic agents. We'll unpack how the extent of the disease measured by body surface area, or BSA, dictates whether we use first, second, or third-line options. And crucially, why toxicity often drives our choice within each of those classes.
Okay, let's unpack this then, starting with that essential first line of defense, the topical agents. The clinical approach here seems heavily based on that BSA involvement. There's a useful clinical pearl in the text, remembering the patient's palm is roughly 1% BSA. So if the disease is localized generally less than 10% BSA, we start right here, often in primary care.
Exactly. The goals are straightforward. Get the patient into remission quickly, but with minimal systemic risk. The foundation, really, is emollients. They're absolutely essential for hydrating that compromised outer skin layer, the stratum corneum, and topical corticosteroids. Corticosteroids act fast. They reduce the redness, the itching, the scaling, mostly through vasoconstriction.
And we classify these by potency, right? The initial strategy sounds pretty aggressive.
It is, yeah. For that initial clearing phase, we often go for a high-potency agent, applied twice daily for about 2 weeks. The source material mentions using occlusion, things like saran wrap or special tape like cordon tape, to really boost absorption and penetration. But, and this is important, we have to reserve the low-potency steroids strictly for those thin-skinned areas like the face or groin. The risk of skin atrophy and systemic absorption there is just too high otherwise.
Okay, so the key takeaway on steroids is, their power comes with a time limit. Use them for quick clearance, then pivot to maintenance or rotation to avoid those long-term side effects, skin atrophy, HPA, axis suppression. But what if the patient needs that sustained, continuous topical control? We can't just keep using high-potency agents indefinitely.
That's the critical pivot point, you're right. And that's why we turn to steroid alternatives. Primarily, the vitamin D analogs like calcipotriene or calcipotriol. Their mechanism is different. They reduce cell proliferation by binding to specific receptors in the keratinocytes. This makes them much better suited for long-term maintenance compared to steroids. That sustained, non-steroidal control is really their big advantage.
What are the main warnings or cautions for the learner here then?
Well, calcipotriene can be an irritant, so it's definitely not for use on the face, strictly contraindicated there. And while it's rare, we do need to monitor usage. Hypercalcemia is a potential risk if a patient uses more than, say, 100 grams of the stuff per week. So it's effective, but you gotta respect the dosing limits.
Got it. Next up, we have the topical retinoid, tazarotene, brand name Tazarac. This one seems to stand out because it normalizes epidermal differentiation, decreases that hyperproliferation, and the text says it promotes longer remission periods than some other topicals.
Tazarotene is an excellent agent, yeah, but it immediately brings up safety flags. We have to remember, it's teratogenic. So for women of reproductive age, counseling has to be rigorous. Often, treatment is initiated during the menstrual cycle just to be sure about non-pregnancy. Also, and this is key for patient counseling, patients need to be warned that their condition might actually look worse initially before it starts getting better. Often you might need to use a mild corticosteroid alongside it at first to manage that initial irritation phase.
Okay. And just a quick mention of the older agents, coal tars and anthralin.
Right. They work by depressing DNA synthesis, which is effective. But the source material confirms what we generally know. Compliance is often poor. They have an unpleasant odor. They stain clothes, sinks, tubs, and cause significant photosensitivity. So just harder for patients to stick with.
So when the topicals aren't enough or the disease covers more than that 10% PSA threshold, we move up the ladder.
Exactly. We transition to systemic therapy, and this usually means involving dermatologists. This is also where baseline lab work becomes absolutely critical for safety checking kidney function, liver function, immune status before starting.
Okay, let's start with the old workhorse, methotrexate, MTX. Its mechanism involves inhibiting folic acid reductase, right? Which stops those rapidly dividing psoriatic cells from replicating.
Precisely. And the dosing regimen is very specific, usually 7.5 milligrams once a week, but given as 3 separate doses over a 24-hour period. This split dosing helps minimize side effects compared to one big weekly dose. And here's a non-negotiable point. Folic acid, usually 1 milligram daily, must be taken on the days the patient isn't taking methotrexate. This helps mitigate some of the potential blood count and GI toxicity. And of course, like many systemics, MTX is contraindicated in pregnancy and lactation.
Okay, so if MTX is the mainstay, then cyclosporine sounds more like the emergency option. Its MOA is powerful, suppressing T-cell proliferation by blocking IL-2 production.
That's actually a perfect analogy. Cyclosporine works fast, promotes rapid remission, so it's great for managing those really acute, severe flares. But that power comes at a significant cost. Its use is strictly limited to the short term, think 3 to 6 months max. That's because of serious dose-dependent toxicity risks, mainly hypertension and nephrotoxicity, kidney damage. So clinicians have to monitor blood pressure and renal function constantly, and patients absolutely must avoid grapefruit and grapefruit products because of major drug interactions.
Right. Moving to the systemic version of tazarotene, we have acitretin, a systemic retinoid. Given the really serious contraindications, especially that huge alcohol interaction that makes its teratogenic potential last even longer, why would a dermatologist choose this over something like methotrexate?
That's a great question. It highlights the clinical trade-offs. Acitretin is often reserved for the more difficult-to-treat types of psoriasis, specifically pustular or erythrodermic psoriasis. In those cases, its ability to normalize epidermal differentiation can be uniquely effective. So, we accept that extremely high safety burden, the absolute contraindication in pregnancy, that 2-month post-therapy alcohol restriction for women because it works well in these severe specific situations. And yes, pre-initiation labs are extensive. CBC, a comprehensive metabolic panel, CMP, and a lipid profile are all required.
Okay. And finally, in this oral category, let's look at the PDE4 inhibitor, apremilast, brand name Otezla. This one's a small molecule that regulates cyclic AMP, CME-MP. The mechanism isn't perfectly understood, though.
Yeah, and what's really interesting about apremilast, especially for the advanced learner, is that it's kind of the outlier here. Unlike pretty much every other systemic agent we just discussed, no prior lab studies are required before starting therapy. That's a huge clinical advantage, makes it much more accessible in some ways. Doesn't mean it's risk-free, though. The most common side effects are GI issues, particularly diarrhea. And caution is needed in patients with a history of depression, as it might worsen symptoms.
Okay, this brings us logically to the biologics. This feels like where therapy really shifts into that highly targeted third-line defense, interacting directly with specific parts of those T-cell mediated inflammatory pathways we talked about at the start.
Absolutely. And because they have such profound effects on the immune system, pre-treatment screening is mandatory, non-negotiable for all biologics. The standard protocol requires current TB testing that could be a PPD skin test, a quantiferon gold blood test, or maybe a chest x-ray if the patient had the BCG vaccine. And hepatitis B and C screening is also required. If hepatitis B is active, it absolutely has to be treated before starting a biologic.
So biologics essentially block the specific inflammatory messages. We see agents targeting established players like TNF-alpha, Enbrel, Humira, but also these newer, even more specific pathways. For the advanced practitioner, why is it important to differentiate between, say, an IL-17 inhibitor like Taltz or Cosentyx and an IL-23 antagonist like Tremfya or Skyrizi?
What's the clinical difference?
That differentiation is all about tailoring the therapy. The IL-17 inhibitors, for example, often give you very rapid, sometimes dramatic skin clearing that can be incredibly important for patients' quality of life and, morale. On the other hand, the IL-23 inhibitors, like Tremfya and Skyrizi, often have these highly convenient dosing schedules, sometimes only 3 or 4 injections per year. That massively improves compliance and is a huge advantage for long-term management. So knowing these differences helps us match the agent to the patient's specific needs, lifestyle, and goals.
Right. And the general contraindications are pretty consistent across the class. No live vaccines, avoid during active infection, caution with history of malignancy.
Correct. Those are the big ones. We should probably also highlight the specific contraindication for infliximab. It's prohibited in patients with moderate to severe congestive heart failure. And just remember, dosing for many biologics is often weight-based. The source uses ustekinumab or Stelara as an example. Patients under 100 kilos get 45 milligrams subcutaneously, while those over 100 kilos get 90 milligrams.
Okay, let's try and tie this all back into clinical decision-making. What does this actually mean for the clinician who's managing that patient with, say, less than 10% BSA involvement?
You stick to that logical, stepwise approach that's outlined in the source material, often shown in algorithms or tables. First line, high-potency topical steroids, maybe with occlusion, plus consistent use of emollients, usually for about 2 weeks. Second line, if they respond well to that initial blast, you then initiate rotational therapy. This is key to maintain clearance while minimizing that long-term steroid exposure. So for example, maybe they use the high-potency steroid just on the weekends and then a vitamin D analog like calcipotriene twice daily during the week. This combination approach really helps reduce the toxicity risk of any single high-dose drug. Third line. Now, if the patient fails to respond adequately to those topicals and the rotational strategy, that's the point where you refer them to a dermatologist. They'll consider options like phototherapy, UVB or PUVA, or initiating those systemic agents we discussed.
And it seems essential to circle back to those lifestyle and psychosocial factors we mentioned earlier: smoking, stress, the non-contagious nature. These conversations feel just as crucial as writing the prescription itself.
Oh, absolutely. Patient education has to hit hard on stress reduction and smoking cessation. These are things the patient can modify. We also need to advise them on careful sun exposure. Gradually increasing exposure time while using sunscreen is key because sunburn itself can trigger really bad flares. And follow-up frequency matters too. Initially, you might see them monthly, then maybe taper to every 2 or 3 months once they're stable. The clinical goals are usually pretty clear: thinning of the scale and relief from that awful itch.
And before we wrap up, maybe just touch on the supporting evidence for complementary therapies mentioned in the sources.
Yes, definitely worth a mention. There is some evidence suggesting high-dose fish oil, think 6 to 15 grams daily, might help by altering the immune response, potentially relieving itching and scaling. Additionally, one study mentioned found that a 0.5% hydrophilic aloe vera cream used 3 times daily showed some promising results with significant plaque clearing. Now, these are generally seen as supportive, right? Not curative on their own, but they can be important parts of a holistic management plan for some patients.
Okay, so to quickly recap the main therapeutic takeaway here. Psoriasis therapy is really hierarchical, isn't it? It moves pretty logically from lower toxicity topicals, your corticosteroids, your vitamin D analogs, up towards more targeted, but also higher risk systemic agents like MTX, cyclosporine, and eventually biologics. And that choice depends heavily on BSA involvement, patient factors, comorbidities.
Exactly. And because of those inherent risks, immunosuppression, potential organ toxicity, careful lab monitoring is just non-negotiable for almost every systemic and biologic therapy you, as the prescriber, will initiate.
Right. That brings us to a final provocative thought for you, the learner, to chew on. Given that we increasingly understand psoriasis not just as skin deep, but as a systemic inflammatory disease, and considering how effectively modern biologics target those root cytokine pathways like IL-17 and TNF-alpha, how might earlier use of these targeted biologic therapies potentially change the long-term outlook? Not just for the skin lesions we see, but for those associated chronic health issues, the joint involvement, the cardiovascular risks that often complicate the disease down the line. It definitely raises an important question for future practice. Thank you so much for sharing this crucial chapter with us for this deep dive. We really hope this review provides a clear, actionable guide for your studies in advanced pharmacotherapeutics.